So let's look at a cartoon of the lungs, and we can see that the lung units when the patient is supine, so the dorsal portion is lying on the ICU bed and the ventral portion is towards the ceiling, that the ventral portions are larger than the dorsal portions, and this has to do somewhat with weight and gravity, gravitational effects on the dorsal aspects of the lung. But interestingly, even in zero gravity, these discrepancies exist, just not to the same degree. So what that means is this is something to do, or this is something independent of gravity and weight effects, and it's thought to be due to shape matching between the lungs and the chest wall. So if you sort of imagine the lungs as a spongy cone, with the tip of the cone being pushed into a cylinder, if the cylinder were the chest wall, and then the tip of that cone has to sort of expand outwards to fill the cylinder, that the portions of the spongy cone would dilate as they do in the ventral portions here. And the question really becomes then, why are the lungs in the chest wall shaped that way? And as I mentioned during the lecture, I thought it was such a bad evolutionary response to have the lungs in this orientation. And then I realized that very shortly that I was just being extremely anthropocentric, and that all of the quadrupeds that have predated us have their lung mechanics optimized with the lungs pointed towards the ground. So all the quadrupeds right there, their sternum is towards the ground, and it's the posterior portion of the lungs that's towards the sky. So if you think of the elegant cheetah chasing the gazelle, both of those creatures have their pulmonary mechanics to be optimized in the prone position. It's the humans that have sort of screwed things up and have been treating our sick co-species in the supine position. It's probably a bad idea. So you can see that this transalveolar or transpulmonary stress is going to be accentuated in the ventral portions when the lungs are in the supine position because of the shape matching issues. So in a situation of severe ARDS, like the patient that had the massive bilateral gastric aspiration, where you have bilateral consolidations, these shape matching problems are accentuated. They're accentuated into the boggy mass of the edematous and inflamed lower lobes from the ARDS, and results in this superimposed pressure that causes collapse of the dorsal units. And so it accentuates the shape matching differences. So the radial traction forces and the transalveolar pressures are greater now in the ventral regions of the lung. And the posterior portion of the lung, the dorsal portions of the lungs here under this edematous mass, were termed by Bone, I think, many decades ago, and he called it sponge lung. So if you can imagine a boggy, heavy sponge kind of being compressed under its own weight at the dorsal portions, and then the ventral portions here is what the baby lung is. And the baby lung is the new FRC, the much diminished FRC of the adult lung, falling to the size of that of a small child. And the important thing here is to understand that the idea of the baby lung, of the diminished FRC, is the difference between stress and strain on the lung. So the strain is the change in FRC over the new FRC. So if your new FRC is only 200 cc's and you give a tidal volume of 200 FRC's, the delta FRC over the FRC is now 1. So 200 over 200 is 1.0. And when you have a strain of 1, the stress is the pressure across that volume that's delivered. In humans, the specific elastance is 12 centimeters of water. So the stress across a strain of 1 is always 12. So if the baby lung were 200 cc's and you were to give a 400 cc breath, that's actually now a strain of 2.0. And so the stress across that strain of 2 would then be 24 centimeters of water. You never really know the volume of the baby lung is the problem in ARDS. Part of the reason for the driving pressure, as described in the last lecture, is that the driving pressure may normalize the ARDS lung to its baby lung size. So what prone position does is it helps homogenize the lung. So as we talked about the baby lung ventrally and the sponge lung dorsally, if you then prone these lungs, then you have a redistribution of these compressed dorsal units, and the transalveolar stresses are now more homogenized. So in the prone position, you have diminished transpulmonary pressure at functional residual capacity, homogenization of the West zones, VQ ratios, and diminished radial traction forces during ventilation on both the airways and vessels, per the Mead model discussed in the last couple of slides. So let's look at it a little bit more abstractly in terms of the Ron diagram that we introduced in the last lecture. So again, this is our patient prone position, supine position. This is the respiratory system. Pulmonary compliance, chest wall compliance. This is in the supine position. And when you're to prone the patient, when you prone a patient, the chest wall stiffens. So this curve shifts down into the right a bit. But because of that homogenation that we talked about in the last slide, the pulmonary compliance actually improves. So you get the situation where the elastance of the chest wall increases, the elastance of the lungs decrease, so the elastance of the respiratory system is actually very similar between the two states, but the physiology can be quite different. So let's just talk about the supine position. So remember she had a PEEP of 20 and you apply that small tidal volume on the y-axis. So now that plateau pressure is still quite high, well above 30. But if you were to have an esophageal balloon, you could measure that the pleural pressure actually rises to 10 or 11 centimeters of water. So the transpulmonary pressure, the pressure from the alveolus to the pleural pressure, is actually diminished. It's not as high as the plateau pressure. So that's what really puts you at risk of the barrow. That's the barrow in the barotrauma. It's the stress across the alveolus. So what happens in the prone position? Well, let's remove the pulmonary compliance for clarity and apply the same breath. Okay, so now the respiratory system compliance is nearly the same, so the plateau pressure is nearly the same, but because the chest wall is stiffened in the prone position, the pleural pressure rises to a much greater degree. So here it looks like the pleural pressure is approaching 20 centimeters of water. So now if you were to say subtract 20 centimeters of water from that 37, the plateau pressure, now actually the transpulmonary pressure is only 17. So it's a much less stress across the capillaries, much less stress across the blood vessels, and therefore a much lower right ventricular afterload at inspiration. So if we're to look at this sort of as a cartoon, what are the hemodynamic implications? So this is in the supine position, we'll have pressure on the y-axis here. And what we're going to see is, relative to the prone position, the pleural pressure doesn't rise as much, but the transpulmonary pressure does rise quite a bit. So that's a small increase in the pleural pressure and a large increase in the plateau pressure. So what are the hemodynamic effects here? Well, if the pleural pressure doesn't rise as much, the pressure in the pericardium doesn't rise as much, so the heart, in terms of its pressure, doesn't rise relative to the mean systemic filling pressure. So if there's not much of a rise in the intrathoracic pressure, there's still this gradient for venous return maintained. So there's still more than adequate venous return to the right heart. But at the same time, that high transpulmonary pressure, remember the alveolar pressure relative to the pleural pressure here, is still quite high. So that kind of compresses the capillaries there and results in a high afterload, so that it's got to pump out against that high afterload. So you can see blood rolling in is still maintained to the right heart, much harder to get that out, so the RV starts to distend. When you prone the patient, right, the pleural pressure rises to a greater degree. So what's that going to do to the pericardial pressure in the heart relative to the mean systemic filling pressure? Well, it's going to rise dramatically, so that gradient is diminished. There's less blood rolling down that hill to that heart, right? But at the same time, the transpulmonary pressure is diminished. So the pressure in the alveolus relative to the pleural pressure is not as great, right? So those pulmonary capillaries are not as smushed. And so there's less West Zone 1, less West Zone 2, and the right ventricular afterload is not as great. So you've got less blood rolling down that gradient and more blood flowing out. So the right ventricular size is diminished. So here's the synthesis of these two diagrams. So this is in the supine position. This is the breath that we just saw with the distending pressures in the red dotted lines there. And we're going to shift this down into the z-axis. It's exactly the same curve. And because pressure is on the x-axis, we can superimpose it with the Guyton diagram here. And as I may have mentioned in previous lectures, the pleural pressure along the chest wall elastance curve will track the cardiac function curve, because it's the x-intercept of the cardiac function curve that follows the pleural pressure. And that sort of makes sense if you sort of think of the entire cardiac function curve as being the heart, well, then it's going to shift rightwards and leftwards on the pressure axis relative to the degree to which the pleural pressure increases. So in that supine position, remember, the right ventricular afterload is high, so the slope of the right ventricular cardiac function curve is not so steep. And when the breath on the z-axis now is dialed in, the cardiac function curve will shift rightwards along the chest wall, elastance curve along with the pleural pressure. And so there'll be a small increase in that pressure relative to the mean systemic pressure. So there'll be less of a decrease in the venous return, less of a decrease in preload. And at the same time, at the end of the breath, that high transpulmonary pressure, the descending pressure seen here, the plateau pressure less the pleural pressure, afterloads the RV. So that will actually afterload the RV to a greater degree. So you see this interesting phenomenon where stroke volume or blood flow is on the y-axis, that you have pulse pressure variation, right? There's been a change, but it's not, there's been a decrease with inspiration, but it's not because of preload sensitivity, it's because of afterload sensitivity. So this would be a false positive pulse pressure variation. So if you remember the stem of this patient, she's paralyzed and she's receiving mechanical ventilation, and she has pulse pressure variation, but that does not mean that she needs fluids. Okay, and then, as I said, the x-intercept of the cardiac function curve tracks the pleural pressure, so that's the pressure in the pericardial space or around the heart, relative to the intracardiac filling pressure. This then becomes a qualitative assessment of the distending pressure of the RV. So if you remember, on her TEE at the beginning of the case, there was RV distension because this pressure is large. So what happens when we prone her? Again, the chest wall is stiffened, so it's shifted rightward. The transpulmonary pressures are less. We're going to shift that into the z-axis now, and we're going to track that with the Guyton curve. But in this situation now, because of the homogenization of the lung and the west zones, and the improvement in P to F ratio on pronation, the right ventricular afterload is immediately improved. So there's an upshift in the slope. And also remember, because of the stiffening of the chest wall, the pleural pressure will rise to a much greater degree now with a given breath. So when you dial that breath in on the z-axis, there's a great shift rightwards from that great increase in pleural pressure from the stiffened chest wall. And now at the end of inspiration, there's relative to the supine position, there's a relatively diminished transpulmonary pressure. So that right ventricular afterload will not shift down at all. So now there's this intracardiac pressure, less pericardial pressure, that's much diminished compared to the supine position. So if you remember no, we didn't talk about that in the case, but if the patient keeps her transesophageal echo in on pronation, one would expect to see the size of the right ventricle diminish. And as interestingly as Dr. Deneau asked me during the question and answer period, he had mentioned very interesting, I believe at least case reports of there being dynamic right ventricular outflow tract obstruction documented in patients placed in prone, and this physiology agrees with that, right? It's similar to HOCM or LVOT obstruction physiology in the left. In that situation, when you lower the left ventricular afterload, you shrink the size of the LV, you increase the velocity across the LVOT, and by Bernoulli's principle, there's a decrease in the pressure in the LVOT, and therefore the interventricular septum shifts into the LVOT, and you may actually have SAM, or systolic anterior motion of the mitral valve, and you ablate the LVOT, and that occurs when you lower the afterload of the left ventricle. A very similar physiology should also apply to the right ventricle. If you were to prone a patient, you're suddenly to lower the right ventricular afterload and diminish the radius of the crescentic right ventricle. Well, if a patient were at risk for RVOT obstruction, one would expect this to happen in certain subpopulations.